Greetings, everybody. My name is Mark Gromski. I'm Associate Professor of Medicine at Indiana University and the Director of Advanced Endoscopy here. And I'm very pleased to have one of our excellent, outstanding fellows, Yervant Ichkhanian, here to talk about our paper in IGIE.
Yeah. Hi everyone, my name is Yervant, and on behalf of the co-authors, I'll be presenting our study under the title The Evolution of Single-Use Duodenoscope Utilization at a Large Volume ERCP Tertiary Care Center. In this study, we reported the outcomes of the single-use duodenoscope at our tertiary care center and its integration across 3 years during the study period. The outcomes that we looked at was the technical and the clinical outcomes, as well as the trends over time in terms of the usage and the performance of the device, as well as the physician-reported satisfaction scores. Among 8,375 ERCPs performed during the duration of the study, single-use duodenoscope was used in 3.2% of the cases, with annual use nearly doubling over time. Most procedures targeted high-risk patient tiers, which are Tier 1 and Tier 2. Tier 1 patients are the ones who had or are known to harbor multi-drug resistant organism, and Tier 2 are the post-transplant immunocompromised patients. 91% of the single-use duodenoscope ERCPs targeted biliary interventions, and native papilla was present in 18% of the cases. Technical success was achieved in 94% of the cases. The main reasons for failure included poor image quality, maneuverability limitations, and the elevator underperformance. The technical failures were managed by switching to a reusable scope. Adverse event remained low at 3%, with no reported post-ERCP pancreatitis in our cohort. Use among low-risk patients, which are T3, which are the patients we do not recommend the use of the single-use duodenoscope, declined during the study period. Native papilla, in which single-use duodenoscope was used, increased over time significantly, and the use for pancreatic duct intervention significantly decreased over time. Failure rate trend was not significantly decreasing throughout the study duration, and user satisfaction improved notably over the study period, especially with the newer device iteration, which addressed the initial concerns around the stiffness and the image quality. There was, however, persistent lower satisfaction scores for papilla positioning, particularly when dealing with complex procedures such as the ASGE Grade 3 ERCPs. Junior faculty drove the majority of the adoption, and the satisfaction improvement only significantly improved among the junior faculty. And with this being said, I wanted to ask Dr. Gromski if he has any discussion or key take-home messages.
Thanks, Dr. Ichkhanian. So we devised this study because a number of years ago, Dr. Stuart Sherman and I published a paper in gastrointestinal endoscopy describing our thought process on adoption of novel duodenoscopes, and in that study, or in that paper, we discussed a three-tier or a tripartite system of utilization of single-use scopes, and in that was highest tier where we suggested usage every time was in folks that we suspect may have a multi-drug resistant organism, such as somebody with primary sclerosing cholangitis, prior positive bile culture of a resistant organism, etc. The middle tier where we were considering usage were those that were immune suppressed, that may not do well with a contaminated scope. These are liver transplant patients. These are patients with cancers being treated with chemotherapy, and then we did not suggest adoption or lack of adoption for the tier 3. And so this study that Dr. Ichkhanian is led and we're publishing is basically the real world adoption using this strategy. And it's the largest, I believe, series of usage. So we have a usage in the hundreds of the single-use duodenoscopes. As he mentioned, the rates started low and rose over time. Still a low percentage, though, less than 10% per year of our cases. Very interesting that the adverse event rate is quite low. We can't make any scientific conclusions from this because it's a retrospective study. of a prospective database. But even looking at every case retrospectively, we could not detect any post-ARSP pancreatitis cases, which actually is quite remarkable, despite our native papilla rate going up over time. The last thing that I wanted to comment on about this paper is the performance scores related to endoscopist experience. This has been noted previously in a publication by Dr. Slivka and colleagues, and it shows that more junior ERCP experts rated the performance higher. Some of that is related to, we hypothesize, we can't prove it, but some of it is likely related to our most senior partners were part of some of the earliest studies with this scope, where it was least refined, and perhaps they had some inhibition of adoption because of that. But what we did find is that over time, we looked at 3 different iterations of the single-use duodenoscope from Boston Scientific, the Exalt, and over time, the subjective performance ratings went up from iteration 1 to 3, for instance, with significant improvements. And so that's another significant finding. And so, in conclusion, I would say that we continue to use the single-use duodenoscope in a small portion of our cases, and it's a very important tool for us for infection prevention and mitigation as part of our overall infection mitigation plan. And moving forward, in this short study period, we were able to study 3 different iterations of a scope, which is extraordinary, which is a iteration process that's much faster than classic reusable duodenoscopes. And so that makes us encouraged that perhaps in the future we'll have applications for ERCP either in scope size, scope performance, scope options that we don't currently have with reusable scopes. And I think that's the exciting part moving forward. Thank you, Dr. Ichkhanian, for this work.
Yep.
And I hope you all will take a moment to click on the link or find this on the website and take a look at the full paper. Thank you.
Thank you.